Hi, this is Elizabeth Edney, and today we're going to go over the basics of CT physics. Today's lecture theme is the office. If you're intimidated by the physics portion of the boards, you're not alone. I promise to keep this lecture as simple and basic as possible. Hopefully this is going to be simple enough for Michael Scott to understand. So we're going to go over 4 main topics, and throughout the lecture I have some practice multiple choice questions you can play along with at home. Key terms and key concepts will also be highlighted in pink. So CT scanners have 4 main components, which we'll cover in more detail. First is the X-ray tube, followed by filtration devices and collimators. And these sit opposite the radiation detector devices, which can be individual or arranged in an array. And in the center, we have our patient, in this case, Dwight Schrute. Here's just another representation of a CT scanner. Again, we have the X-ray tube here, sitting opposite the X-ray detector here, and both of these rotate around the patient. Then signals from the detector are sent to a computer, which creates an image. So let's look more closely first at the X-ray tube. These follow the same basic concepts as radiographic tubes. The focal spot is the portion of the anode that receives the electron beam from the cathode. It's large for CT compared to, say, mammo, where the focal spot is 0.3 to 0.6 millimeters. For CT, it's about 1 millimeter. So this means it can tolerate a large amount of heat loading. The anode is typically made of tungsten, and some have a rotating vacuum to help dissipate heat, and these are very expensive. So if we zoom into the X-ray tube, we can see a little bit more detail. Here's that anode that's made of tungsten, and current flows from the cathode, which is labeled as the filament in this picture, to the anode. As that happens, energy is lost and it's dissipated as X-rays here. So the anode is just a big piece of metal, in this case tungsten, and it has 2 jobs. One, to turn the electronic energy coming at it into radiation, and 2, to dissipate heat. How efficiently it does those jobs depends on the atomic number of the anode material and the energy of the electrons. So tungsten is good because it has a high atomic number of 74, so it doesn't melt with high temperatures, and it also has a low evaporation rate. If we're going to compare the anode to an office character, who do you think it would be? Obviously, the anode is going to be Creed because he's approximately 74 years old. So there's a little mnemonic to remember the atomic number of tungsten. And he's been through a lot in his life. So obviously, he's the most mentally and physically tough employee in the office. The tube needs a large high-frequency power supply, and the voltage usually ranges from 80 to 140 kilovolts. MA stands for milliampere, which is a unit measuring the current, and it's up to 1,000 for CT. Milliamps times the seconds gives us MAS, and this is a unit we use to describe the current a point on a patient receives over the time that that point is in the beam. Depending on the scanner, a full rotation takes 0.3 to 2 seconds. So this concept also relates to the width of the beam and the table speed. The tube axis is placed perpendicular to the imaging plane to reduce the heel effect, a concept that you're probably familiar with from X-ray physics. So a higher anode angle will result in less of a heel effect. And modern CT scanners use a slip ring technology. If the machine had wires, they would all get tangled as it rotates around the patient. So instead, the slip ring are these contacting parts that just slide over each other. Basically, you just need to know that the slip ring eliminates wires and it improves CT performance. Here's our first practice question. CT beam shaping filters or bowtie filters are often made of what? Aluminum, copper, molybdenum, Teflon, or tin? And the answer is Teflon. Now we'll move on to the second component of a CT scanner, filters. The filter is circled in purple here on our graphic. And these are typically made of copper or aluminum, and their job is to remove the low energy X-rays that would only serve to increase the patient dose. This results in a very penetrating X-ray beam, and it reduces beam hardening artifact, which is a key concept. So let's say that again. Filtration reduces beam hardening artifact. A bowtie filter is used, which will filter less in the center and more on the edges. This helps compensate for the shape of a patient's head or body, which is going to be more thick centrally, meaning it will attenuate more of the X-rays centrally. Having this shaped filter makes the X-rays that end up reaching the detector side be more uniform. Comparing images created without a filter and with a bowtie filter show that the bowtie filter creates a more uniform image with better contrast to noise. So let's review some high yield points about bowtie filters. They compensate for uneven filtration, they reduce scatter, and they reduce dose. Here's another practice question. CT collimation is most likely used to change X-ray beam what? Width, intensity, half value layer, or isocenter? And the answer is width. So now we're moving on to collimators, the component found under the filter. Collimators are used to reduce scatter, and they're found both at the X-ray tube side and at the detector side. You can see after the beam passes through the filter, the collimator is made of lead and it acts as a corset, reducing the width of the X-ray beam. In our modern multi-slice scanners, collimators determine the beam width. In a single slice scanner, they determined the slice thickness, but that's now determined by post-processing. If we have a wider beam coming through the collimator, that means we'll reduce the scan time because that wide beam covers more area in each turn. We're going to reduce motion artifact because we're reducing the scan time, and we'll increase partial volume averaging because that beam is more divergent, and the radiation dose will be unchanged. Essentially, the changes cancel out because it's a wider beam, but decreased scan time and unchanged current. Our final component of the CT scanner is radiation detectors. Each detector measures the radiation transmitted through one ray. Detectors are typically devices called scintillators, which make light when they get hit by an X-ray. They're then coupled to light detectors called photomultiplier tubes and photodiodes. In the picture, you can see X-rays hit the scintillator, get converted into light, that hits the light detector, and then gets converted into energy. These detectors respond quickly and are highly efficient. After the photomultiplier tube converts the light to energy, all you need to know is that what we call computer magic happens. The computer takes that energy, which is an electronic signal proportional to the incident radiation, and converts it to a grayscale pixel. These are some common materials radiation detectors are made from: cadmium tungstate, cesium iodide, calcium fluoride, or bismuth germanate. Here's another picture showing the photon hitting the scintillator and getting converted into light. To adjust the slice width, you have to adjust detector width. Obviously, we're not going to manually change the machine parts every time we want to change slice thickness, but we can effectively add or subtract adjacent detectors. For example, if we have a 1.25 millimeter wide detector, we can combine every two detectors together to get 2.5 millimeter slices. It makes sense then that the minimum slice thickness is determined by detector width, which is a high yield point. Minimal slice thickness is determined by detector element aperture width in a modern CT. Here's another view of our tube sending X-rays through a patient. Here is the patient, which then have different energies when they reach the detector. This profile line here shows how the rays in the center, which might have to go through multiple thick layers of bone in the skull, for example, usually have a lower energy hitting the detectors than the rays in the periphery. So that covers our first portion of CT hardware. Next, we're going to talk more about how the image that we read is acquired and processed. This is the point in the lecture where we normally watch a couple of funny videos, but since we're doing this virtually, I suggest you go give your brain a 5-minute break, walk around, and then come back for our next topics. Okay, so we're back. With old single detector CTs, one slice was generated every 360-degree turn. Now with multi-detector CTs, there are more detector arrays that allow us to acquire multiple slices per 360-degree turn. For a 64-slice CT, 64 slices are obtained per rotation. These thin slices allow us to create multiplanar reformats and have high temporal resolution, which is the ability to see image detail in the smallest window of time. The total number of individual detector elements for a 64-row scanner is most likely what? 64 by 1, by 8, 100, 800, or 10,000? The best answer is number 4. They range from about 650 to 800-ish elements per row. Remember that with a single detector, the beam width equaled the slice width, or B equals S in this picture. With a multi-detector array, these combinations of detectors equal multiple slices, and we can manipulate the slice width by combining them in different ways. So to acquire an image, we have a certain size beam of X-rays passing through the patient. For abdominal imaging, that beam is typically around 50 centimeters. A ray is a measure of the total X-ray attenuation along a line from the focal point to a single detector. Each detector detects one ray. An important concept is that these X-rays in CT are highly filtered and have a high kV. Their average energy is 75 keV. So CT X-rays are highly filtered, high kV. The intensity of the ray depends on how much of the beam was attenuated or absorbed by tissues in the patient. You can see in the picture an X-ray passing through mostly lung tissue, which is essentially air, is going to have a lot more energy left over than an X-ray that passes through the sternum and the vertebral body. There. A projection is all the rays at a given X-ray tube angle, or a series of rays that pass through the patient at the same orientation. A 64-slice CT means that 64 projections are created per tube location. The beam width would equal the number of slices times the slice thickness. So for a 64-slice scanner, that might be 64 times 0.6 millimeters, giving us a beam width of about 40 millimeters. We obtained multiple projections per turn of the CT machine, up to 1,000. The linear attenuation coefficient, or LAC, is a measurement of how well X-rays move through a given tissue. If we plot all of our raw projection data, they form a sinogram like this. The computer uses a process called back projection to make images by determining the linear attenuation coefficient for each pixel. I realize that whole process can kind of make your head hurt just thinking about it. Basically, we have to understand the general concept and realize that the computer is just doing a lot of math. So here's a simplified example. Say we have this 4-square problem where we want to solve for A, B, C, and D. This is like a 4-pixel image. We know that the sum of A and C is 6 here, and the sum of B and D is 8, and so on. This is like how we know the value of a projection after it passes through the patient. The same way we can figure out that A equals 2 and B equals 5, the computer can figure out that A should be a white pixel for bone and B should be a black pixel for lung, for example. This is essentially the computer magic that I referred to earlier, where the computer makes an image by manipulating that sinogram data. This YouTube video here has a nice demonstration of the process over minutes 12 to 14, which I recommend watching. Here's another question. In CT, the kernel used refers to the amount of filtration, the specific KVMA setup, the mathematical reconstruction filter, the mascot of Kentucky Fried Chicken, or something you'd buy from a Boy Scout. The answer is the mathematical reconstruction filter. Another question, use of a bone filter as opposed to a soft tissue filter for reconstruction would improve what? Contrast, scatter rejection, noise, spatial resolution, or bits and bytes data storage? And the answer is spatial resolution. Using the process that we just described, the result is a blurry picture. So the data are convoluted with a mathematical filter or a kernel to remove the blur. This is called filtered back projection. Here's where we want to introduce the concept of spatial resolution, which is the ability to distinguish small objects that are close together. Line pairs per centimeter illustrate the concept of spatial resolution. On the top row here, it's fairly easy to see that each line is separate from the next because this represents 6 pixels per line pair. On the bottom row down here, it's very hard to distinguish each individual line because they're much lower pixels per line pair, 2.05. And CTs have different filters for different purposes, which we've all seen doing imaging. Bone or soft tissue are two of the most common, and these filters trade off spatial resolution for noise. For example, a bone filter provides very high resolution, but lots of noise. Contrast resolution, or noise, is the ability to distinguish small differences in object density from its surroundings. Here's an example. This image has been created with a bone filter. We see good spatial resolution, and you can see all of the trabecular detail in the bone. But we see lots of noise. If you're going to draw a pencil around the border of the pectoralis muscle, for example, it's hard because the edges aren't very crisp. It's tough to tell a difference in the density of that fat muscle interface. And here's the flip side where we have an image created with a soft tissue filter. The image on screen left has great contrast resolution, aka very little noise. We can clearly draw a pencil around the borders of the left kidney here. And that soft tissue and fat interface is very crisp. But the spatial resolution is poor. When we change the window level settings to look at bone, you really don't see that trabecular detail like we did on the previous slide. That brings me to an aside. Don't confuse filters with windows. The filter is something that our techs apply on the machine side. The window and level settings are something that we manipulate at the PAC station. So for a chest CT, we usually get soft tissue, lung, and bone filtered images. And we can change the window level settings on each one of those series, but that's just manipulating the grayscale of the image, not the resolution. So don't confuse filters with windows. Newer CTs use a process called iterative reconstruction rather than filtered back projection. And it's not important to know the details of this, but just know that iterative reconstruction can correct for noise and allows us to use a lower dose. Iterative reconstruction is a more modern technique allowing for lower dose, basically. A CT image is thus a map of linear attenuation coefficients. So these are given a number called Hounsfield units, and it's just based on an arbitrary definition of air as minus 1,000 and water as 0. It's important to know that Hounsfield units are approximate, and they can vary depending on the scanner, the KV, and the filtration that are used. Here's a chart showing different Hounsfield units. So water is 0, fat is usually the low negative numbers, bone is up to 1,000, for example. Okay, pixel size in CT is which of the following? Field of view over matrix size, matrix over field of view, 2 times the field of view over pitch, or 2 times voxel size. The answer is field of view over matrix size. Field of view is the area scanned. Typically for the head, it's around 250 millimeters. For the body, around 500 millimeters. And the matrix that we use is usually 512 by 512. That's the number of pixels per image. So pixel size is the field of view over the matrix. For example, if we have a 500 millimeter field of view, we divide that by our matrix, which is 512, and get 0.98. You can improve spatial resolution by making the pixels smaller, and you can do that by either decreasing the field of view or increasing the matrix. Typically for CT, we deal with the 0.3 to 0.8 millimeter pixels. For a given slice thickness, a voxel and a pixel have the same width and height. A voxel is like a cube. It has a third dimension, shown here. Whereas a pixel is like a box. It's just 2D, and that is the average attenuation of a voxel. So here in the voxel, you can see different grayscale values, and in this 2D pixel, you see the average grayscale value. On our CT images, we usually look at 2.5 to 5 millimeter slices, and pixels have over 4,000 shades of gray. So our window width and level affect the image display by assigning a given Hounsfield unit number given brightness levels. A way to remember this is level starts with an L, and that's what you're looking at. So the typical level is going to be about the average number of Hounsfield units for what you're looking at. So for the abdomen, say a liver, if you drew a Hounsfield unit ROI over the liver, you'd probably get somewhere around 60. So our window level setting for an abdomen is 60 and 150. The width is the range of what you can see. So when we're looking at a lung, we're seeing air, we're seeing bone, we're seeing a much wider range of Hounsfield units. So our window number is going to be the highest, 1,500 approximately. There's a reminder of our different Hounsfield units for different densities. Go over quickly CT scanner generations. The first generation CT scanners were translate rotate. That meant they had one X-ray beam and one detector, and they just moved 1 degree at a time until 180 degrees were covered. It took a very long time to perform a CT, about 4.5 minutes just for a head, and it took too long to image the chest or the abdomen. The second generation scanners introduced fan beam and multi-detectors, and these added 3 detectors 1 degree apart, so they could rotate 3 degrees at a time. It reasons then that this cut down the scan time by a factor of 3, and eventually about 53 detectors were added so they could start to image the trunk. Third generation scanners used rotate technology, which we currently use, and had a wider beam with over 700 detectors. Fourth generation are used for research. They're cost prohibitive to use in clinical settings, but the source rotates while the detectors stay stationary. And this YouTube video at these different time points explains a little bit more about generation scanners if you're interested. Okay, so a review of our last 74 slides is that the CT fires off X-rays as it spins, the table moves the patient through, The detectors, which are highly efficient, have a lot of information that looks like a wavy mess called a sinogram. Then a bunch of math happens, filtered back projection or iterative reconstruction, and we get a picture. So just kind of keep that big picture in mind. That's what we've learned so far. That's how we get our CT image. Our next topic is CT techniques. And here's a question. In multi-detector helical CT scanning, the detector pitch, 1, is the table movements per 360-degree rotation divided by detector width. 2 is the table movement per 360-degree rotation divided by the collimator width at isocenter. 3 has a typical value of 2 to 3 for clinical use, or 4 is associated with partial scanning for values less than 1. Our answer is 2. It's the table movement per 360-degree rotation divided by the collimator width at isocenter. And pitch is an important concept, so we'll talk more about that. All modern scanners are helical, and pitch has to do with the relationship between patient movement and tube rotation. For modern CTs, pitch equals the table movement per rotation over X-ray beam width. Remember, we've already learned that beam width is the same as collimator width. So if the pitch is 1, that means that beam width is equal to the distance the table moves in 1 revolution. I like this picture on screen right for showing the concept of pitch. You see, if pitch equals 1, like in this top picture, there's no gap in the parts of the patient's body that are imaged. If pitch is 2, like the middle picture, that means the beam width is smaller than the rate of table movement. So there's gaps like this in what we're imaging. If the pitch is 0.5, that means there's overlap in what's being imaged, or the table speed is less than the beam width. Here's a practice question. The table movement is 12 millimeters per tube rotation, and the beam width is 8 millimeters. What is the pitch? So the answer is 1.5, 12 divided by 8. Increasing the pitch will increase scan time and radiation dose, increase resolution, decrease scan time and radiation dose, both 2 and 3, or both 1 and 2. I'll give you a second to think. It will decrease scan time and radiation dose. As you might realize by now, a low pitch value, anything less than 1, will give us very good spatial resolution, but at the expense of high radiation dose. Another concept we'll cover quickly is dual source CT. These have 2 tubes or X-ray sources which may operate at different kVs. This allows faster data acquisition and it can provide a lower dose. We can also create virtual non-contrast images by having 1 kV near the K edge of iodine and subtracting it from the other. Let's look at that. The 80 keV image here is noisier because fewer X-rays are penetrating the body, but it has higher contrast because 80 keV is closer to the K edge of iodine. If we average those two together, they make a composite image that's closer to what we're used to seeing, with a keV of around 120. We can also do stone composition analysis, and this whole process has lots of implications for clinical use. Think about how we could do all of our ER protocols with contrast, but then if you see an incidental adrenal nodule that's indeterminate, you don't need to follow it up with the adrenal protocol scan. You just look at the virtual non-contrast and you can potentially diagnose it as an adenoma. Or multi-phase exams like an endograph follow-up can just be done as a single phase. We can also potentially salvage pulmonary embolism studies that have bad bolus timing. So we're manipulating the image based on these 2 different acquisitions. We can get a bone-only image, for example, virtual non-contrast like we talked about, or we can do these iodine overlays. CT common techniques. First, we do a scout, which is a radiograph that determines the area that we're going to scan and the tube current modulation. You, or the technologist, picks the kV and the MAs. kVs typically range between 80 and 140. And then tube current modulation is a technique used by the scanner. So the MA is automatically adjusted based on the patient thickness to reduce the dose. If we had a fixed MA, shown by this red line, the dose would hardly ever be correct for the area of the body that we're scanning. The scout image allows the machine to guess more closely an appropriate current level. So if we have an area that has lots of bone, lots of dense stuff, tissue, the machine is going to know to automatically apply a higher current to penetrate all of that. Whereas when we have an area that's less dense, more lung or more air, the machine knows from that scout radiograph that it doesn't need as much current to penetrate that portion of the body. Gated CT is another technique most often used for cardiac imaging. The heart is always beating, hopefully, but it's most still in diastole, so that's our best time to image the heart from a CT standpoint. We can track the cardiac cycle with an EKG and then prospectively set the machine to scan in diastole. That's shown here. This is also called the step and shoot method. This gives us a relatively lower radiation dose, but it doesn't provide functional information. Another method is retrospective gating, where the machine scans for the entire cardiac cycle, and then it back calculates when diastole was and creates images from the information acquired during that time, shown here. Retrospective gating has a very low pitch and a high dose. So if the tech is asking you to protocol a scan, do you want it gated, you might not want to choose that method if, for example, it's a trauma scan on a very young patient, because we know it's going to have a much higher dose. During CT fluoroscopy, the tube is continuously rotating, and that gives us multiple images per second, which helps with procedural applications. CT fluoroscopy best minimizes radiation exposure by reducing which of the following? Beam filtration, focus size, tube current, slice thickness, or matrix size. Tube current is the answer. So in CT fluoroscopy, we're not necessarily trying to give the highest resolution images, so the tube current can be lower, and that greatly reduces the dose. This image shows radiation-induced alopecia caused by repeated CT angioscans, which were performed over a limited section of the head in this patient who had a ruptured ACOM aneurysm. We know from protocoling studies that different types of scans use different contrast timing. Our routine body scans, for example, have a fixed delay, with the scan occurring about 65 to 70 seconds after the intravenous injection. Arterial phase studies might use more dense contrast and a faster rate of injection. Saline chasers are used to push the contrast from the tubing and the peripheral veins further into the central veins, which can help reduce the total contrast volume that's given, can increase peak attenuation, and can reduce streak artifact. One method for setting the scan timing is to select a target location from our scout, shown here, and then inject a small test bolus of 15 to 20 milliliters of contrast. A low-dose scan is performed right at that location that we specified from the scout. An ROI is drawn in a target structure, shown here, like at the aortic root, and then the time it takes for that structure to reach its peak attenuation is plotted in a curve, shown here. Bolus triggering is similar in that an ROI is placed in the structure of interest, but the full contrast dose is injected right away, and the ROI in the target structure is continuously monitored. Then when it reaches the desired threshold of attenuation, the scan will start. Each method has its pros and cons, which you can pause and read through this slide here if you're interested. Our last section is artifacts, and I have a couple memes for our mini mental break before we finish up. When the CT techs call you with a question about scan technique, you might feel like Michael Scott in this scene. These are the 4 phases of an overnight shift. This is how I feel some days on the ultrasound rotation. Okay, so this section in my experience is high yield material for boards question. One way they seem to like to ask questions is by comparing different modalities or asking how changing one aspect of a scan will affect another. So comparing CT to digital radiograph, CT has better contrast, has worse resolution, has larger pixels, and larger dose. Conversely, radiographs have worse contrast, better resolution, smaller pixels, and lower dose. This is more high-yield material. We have a list here of factors that affect spatial resolution and factors that affect contrast resolution. And I'll go in more depth for some of these. So first, let's talk about detector width. A smaller detector will improve spatial resolution. And here's a visual example. Remember, slice thickness is directly correlated to detector width. This tibial plateau is fractured, and the fracture appears more distinct in the image at screen left, which is a 1.25 millimeter slice, versus the 5 millimeter slice at screen right. Now let's look at the reconstruction filter. For example, a bone filter will give us higher spatial resolution. The right rib fracture, shown by the red arrow, and the spinous process fracture, shown by the green arrow, are much more distinct in this bone filter image than the soft tissue filter on the right. Moving on to factors affecting contrast resolution, the first thing is what I think of as just the number of X-rays. This can be manipulated by changing current, the kV, or the pitch. Basically, anything that increases the radiation dose will give you better contrast resolution. Here's an example showing that contrast improves as current increases. These are 4 phantom images of low contrast objects. This first one is performed at 800 MAS, B at 400 MAS, C at 200, and D at 100. The visibility of the objects improves with the higher current. You can see these small dots, for example, are visible in the higher current image, and you'd really be kind of hard-pressed to see them in this lowest current image, especially the even smaller ones down here, whereas they're visible to us in the high current image. If we have an image that's too noisy, like this one at the farthest right, D, I should label here. That's usually caused by too few X-rays, aka too low of a dose or too much soft tissue. Slice thickness also affects contrast resolution. The thicker the slice, the more X-rays we have essentially, and the less noise. Here are those low contrast objects again, but A is a thick 5 millimeter slice. B is 2.5 millimeter, C is 1.25 millimeter, and D is 0.625 millimeter. So the thick 5 millimeter slices have better contrast resolution. Again, we can see those low contrast objects much better than we can in the 0.6 millimeter slice. Changing slice thickness will cause important trade-offs. If no other parameters are changed, the number of detected X-ray photons will increase linearly with slice thickness, which is important. So if we go from a 1 millimeter to 3 millimeter thicker slices, the number of detected photons will triple, and the signal to noise ratio increases by the square root of 3, or 73%. If we change from 5 millimeter to 10 millimeter slices, the number of detected photons doubles, and the signal to noise increases by about 41% because the square root of 2 is 1.41. These kinds of changes also lend themselves nicely to test questions. As far as the trade-off, though, a thicker slice will decrease spatial resolution in the slice thickness dimension. Conversely, thin slices improve spatial resolution in the slice thickness dimension and reduce partial volume averaging. When a thin slice exam is performed, usually the current is increased to compensate for the loss of X-rays. An artifact in CT is any systemic discrepancy between the CT numbers in the reconstructed image and the true attenuation coefficient of an object. CT images are prone to artifacts because of the vast number of independent measurements that need to be processed in order to produce an image. The first artifact that we'll cover is partial volume averaging. This occurs when you have a dense thing next to a not dense thing, and the computer averages the two together. And this is most often seen in small lesions, less than a centimeter in size. The fix is to make thinner slices. These will be noisier, but you can acquire thinner slices and then add them together. Motion is an artifact that we're all pretty familiar with. And the fix for motion is usually just to repeat the scan, or you could get a faster scanner. Beam hardening occurs in high density areas, commonly like here at the level of the temporal bones. And this is related to preferential absorption of low energy photons, creating a hardened beam of high energy photons. So you get the center of the image appearing darker than the periphery because the X-rays that go through the middle are hardened more than the ones that go through the periphery. You also see these dark and light streaks when there are two dense objects. The X-rays that go through both of them are more attenuated than those that pass through one. So decreasing slice thickness or increasing filtration can also help with this. Star or metal artifact occurs when you have a high density material like metal that attenuates everything, and that creates a problem with the math during the filtered back projection. Potential fixes are to remove the metal. You could angle the gantry or use metal reduction software. Out of field artifact is caused by things outside the field that still attenuate X-rays, and that messes with the computer's math as well. These are often related to a body part like the arm, which obstruct detectors and harden the beam. So the fix is to move those objects. The artifact shown here is caused by which of the following: beam hardening, metallic implant, a faulty detector, patient motion, or scattered X-rays. The answer is a faulty detector, and this is a pretty commonly asked board question on practice bank sets. So ring artifact is caused by one or more faulty detectors seen as a ring, and it can be a calibration problem. Our fix is to call a service representative or to who can recalibrate the detector. In CT, if KV and MAS are kept the same, increasing slice thickness does what? Decrease image contrast, increase spatial resolution, decrease noise, or reduce partial volume averaging. Answer is 3, decreases noise. Photon starvation artifact is caused by high attenuating areas, classically the shoulders, or a large patient. We have an example from the office here, which result in photon starvation. And it looks like streaking on the image. We can fix photon starvation artifact with automatic tube current modulation, which will increase that dose through the thick area, essentially adding photons to penetrate. Filtration methods can also smooth the data. Here's an example like we've all seen from patients that barely fit in the scanner. There just aren't enough photons to penetrate the patient's body habitus. When compared to radiography, CT has what? Superior spatial resolution and image contrast, inferior spatial resolution and image contrast, superior resolution but inferior contrast, or inferior resolution but superior contrast. The answer is inferior resolution, but superior contrast. So that wraps up CT physics for today. Thank you if you made it this far, and I wish you all the best of luck on radiology boards.